So the preterm labor, let's talk about the background and scope. The incidence of preterm labor in India is reported to be 23.3%, with preterm delivery in 10 to 69% of the cases. In 2020 alone, India recorded an estimated 3.02 million PTB, representing over 20% of the global burden. The preterm delivery accounts for approximately 75% of the neonatal death and is a leading cause of perinatal morbidity and mortality. The definition. Preterm birth is the delivery of a live infant before 37 completed weeks of gestation. The causes include preterm labor, that is spontaneous labor with intact fetal membranes before 37 weeks of gestation, premature rupture of membranes before 37 weeks of gestation. The criteria for preterm labor, it includes the regular uterine contraction after 20 weeks or before 37 weeks of gestation, 4 or more in 20 minutes, and accompanied by one or more of the following, that is cervical dilatation of 2 centimeters or more and cervical effacement of 80% or more. Now we categorize preterm labor as suspected or threatened preterm labor, which includes uterine contraction without cervical dilatation, diagnosed preterm labor, which includes uterine contractions with cervical changes, the dilatation of more than 2 centimeters, and established preterm labor, that is the uterine contraction along with progressive cervical dilatation from 4 centimeters. Now, the categories of preterm birth. The preterm birth is categorized based on the gestational age of the baby at birth. Extremely preterm is born before 28 weeks of pregnancy. Then very preterm, born between 28 to 32 weeks of pregnancy. Moderate preterm, born between 32 to 34 weeks of pregnancy. And late preterm, born between 34 to 37 weeks of pregnancy. This has been taken from World Health Organization, which was reviewed on 18th April 2025. The link has been provided. The risk factors for preterm birth. So there are some modifiable risk factors and non-modifiable risk factors. The risk factors which are modifiable include strenuous work and activity, poor nutrition, cigarette smoking, illicit drug use, bacteria, UTI, infections.
Dr. Shubhi, your slides are gone. Please,
Dr. Shubhi, you'll have to share your screen again.
Yeah.
Can you see, ma'am, now?
Right.
So, bacteria, urinary tract infection, gingival disease, lower genital tract infection. And non-modifiable risk factors includes prior preterm birth, age more than 40 years, low pre-pregnancy weight, socioeconomic status, suboptimal prenatal care, cervical injury or anomaly, uterine anomaly, premature cervical dilatation of more than 80%, over-distended uterus and vaginal pain. Now coming on to the pathogenesis of preterm labor, it may be a physiological process that started too soon or a pathological process following an abnormal stimulus, like uterine distension, maternal-fetal stress, and infections. Uterine distension and maternal-fetal stress also associated with these infections implicated in 40 to 50% cases of the preterm labor at early gestation. Bacteria can get access to intrauterine tissue through transplacental transfer into maternal infection, retrograde flow of infection into peritoneal cavity via fallopian tube, and ascending infection from vagina and cervix. Then coming on to the symptoms of preterm labor, a woman presents before 37 weeks of pregnancy with symptoms suggestive of preterm labor such as abdominal pain, pelvic pressure or discharge, having not undergone any clinical assessment including speculum or digital examination, dull backache, regular or frequent contraction with tightening and ruptured membranes. The risk assessment for PTB.
Your presentation is again gone. Please share it again.
Yes, sharing it again.
There's a problem with your data, I think.
Yes, there is. I don't know. Not able to figure out. I think it just started again. The risk assessment for PTB in the antenatal period, we have to take the history of the patient. The prior preterm delivery is a strong predictor of recurrent PTB. And physical assessment includes speculum and digital examination. Cervical integrity and prior cervical injury has to be ruled out. Helps access the risk of cervical insufficiency or previous trauma. Screening for asymptomatic bacteria, sexually transmitted disease, and bacterial vaginosis. Then next, coming on to cervical length, the transvaginal ultrasound has to be done. The cervical length of less than 25 mm is considered to be a strong predictor of preterm labor. The laboratory tests includes vaginal pH, wet smear, and wet test for identification of bacterial vaginosis. Complete urinary culture, accounting for a colony count of more 10 to the power 5 colony forming units per milliliter of urine from a midstream sample. Now, vaginal swab test, the presence of fetal fibronectin, elevated levels of positive fetal fibronectin indicates the risk of delivery. Negative predictive value is excellent. Negative test implies negligible risk of PTB in the next 7 days. Positive predictive values are equally good, and levels of more than 200 should be used as a cutoff for antenatal corticosteroids and in vitro transfer. Now, discussing some recent advances in predicting preterm labor, which were discussed in AICOG 2026, there are biomarkers available for predicting preterm labors, such as placental alpha microglobulin 1, which indicates membrane stress or disruption, phosphorylated insulin-like growth factors binding protein, first trimester biomarkers like PAPE, angiogenic and anti-angiogenic factors, and uterine artery Doppler analysis. And second trimester blood test includes ratios of insulin-like growth factor binding protein and sex hormone binding globulin. Now, prevention of preterm birth and initial and further risk assessment. The risk assessment has to be done, like I earlier discussed when we take the history. Then risk assessment including smoking, maternal age, screen for UTI, screen for genital tract infection, history of preterm birth, history of cervical injury, history of mid-trimester losses, previous preterm prom, cervical injury, and cervical cerclage. The utility of preterm labor prevention surgeries, there are strategies that have limited efficacy and that may have some benefit. The strategies that have limited or no proven efficacy are bed rest, pelvic rest, intensive education, screening and treatment of asymptomatic lower genital tract infections, treatment of gingival disease, and empirical broad spectrum antibiotic therapy. Now, strategies that may have some benefit are prevention and early diagnosis of infections, maybe it's sexually transmitted infections and genital urinary infections. Now, also cessation of smoking and illicit substance use. Now, elective cerclage, if indicated, folic acid supplementation and vitamin D supplementation are among the few. Prophylactic vaginal progesterone, it is a very useful strategy in preterm birth. For women who have either history of spontaneous preterm birth or mid-trimester loss, we recommend prophylactic vaginal progesterone between 16 to 34 weeks of pregnancy. And on transvaginal ultrasound scan done between 16 to 24 weeks, which show a cervical length of 25 mm or less, we can use prophylactic vaginal progesterone. While using the vaginal progesterone, this treatment has to be started between 16 to 24 weeks of pregnancy and can be continued till at least 34 weeks. Coming on to cervical cerclage, it is indicated for women with previous spontaneous preterm singleton gestation. Cervical length, post-operative cervical cerclage patients can be administered tocolytics. History indicated cerclage should be offered to women who have 3 or more preterm deliveries or mid-trimester losses. An ultrasound guided cerclage should be offered to the women who have a cervical length of less than 2.5 centimeter if they had 1 or more spontaneous preterm birth or mid-trimester loss. Now, women with singleton pregnancy who can be offered a referral for short cervical length between 16 to 24 gestations are who have a history of mid-trimester loss or preterm birth between 16 to 34 weeks of gestation, women with history of pre-labor rupture of membranes in previous pregnancies, women with a previous large loop excision of transformation zone of more than 10 mm depth. Now, consider rescue cerclage for women between 16 to 27 plus 6 weeks of pregnancy with a dilated cervix and exposed unruptured fetal meat. Now, talking about the tocolytics in the management of preterm labor, the Federation of Obstetrics and Gynecological Society of India recommends chocolysis to allow time for antenatal steroids and magnesium sulfate administration for neuroprotection, reduce neonatal complications including IVH, respiratory distress syndrome, facilitate patient transfer to specialized centers if needed. Acute tocolysis involves short-term use of tocolysis. Now, globally, various tocolytics are used like atosibin, nifedipine, isocycline, indomethacin, and nitrooxide donors. However, in India, the CDSCO approved drugs are atosiban and isocycline. Now, coming on to nifedipine.
Dr. Shubhi, your screen
Yes,
is
Yes, and yes. Nifedipine, the mechanism of action of nifedipine is it inhibits the calcium reuptake by voltage-dependent calcium channels in myometrical cell wall, resulting in vascular and smooth muscle relaxation. It is the best first-line tocolytic agent recommended by RCOG as the first line of treatment. The dosage is 20 to 30 milligrams SAT followed by 10 to 20 milligram every 6 to 8 hours, and the maximum dose is 160 milligram per day. The side effects include dizziness, flushing, headache, hypotension, and the contraindications are hypertension and congestive cardiac failure. Now, coming on to atosiban, it acts as competitive antagonist of human oxytocin and vasopressin at receptor level. It downregulates the oxytocin receptors and competitively inhibits the uterotonic action of oxytocin on myometrium and descendants. Recommended by RCOG as the first line of management, first line agent in management of preterm labor. The dose includes 6.75 milligram bolus over 1 minute, followed by infusion at 18 milligram per hour for 3 hours, and then 6 milligram per hour for up to 45 hours. Maternal antenatal corticosteroids. Consider maternal antenatal corticosteroids in 24 to 26 weeks of pregnancy who are in suspected or established or having a planned PTB or have pre-prom after discussing with the patient or care. And the maternal antenatal corticosteroids have to be offered to 26 plus 33 plus 6 weeks of pregnancy who are in suspected labor. The choice of corticosteroids, as Dr. Mrinalini has already discussed, we know about it. Dexamethasone or beta-methasone either can be given. Coming on to neuroprotection, neuroprotective agent magnesium sulfate is given for neuroprotection. We can offer intravenous magnesium sulfate for neuroprotection of the baby between 24 to 32 weeks of pregnancy who are in established preterm labor or having a planned PTB within 24 hours. The dosage regime is loading dose of 4 grams diluted with 12 ml of normal saline is given IV over 5 to 10 minutes using a 20 ml syringe. It is generally well tolerated but requires monitoring for toxic effects including respiratory depression and cardiac arrest at supertherapeutic levels. Common side effects include nausea, headache, drowsiness, blurred vision. So magnesium sulfate can cross the placenta, potentially causing respiratory and motor depression. Now, antibiotics in preterm labor or pre-prom. The drug of choice is erythromycin used in the dose of 250 milligram TDS orally for 10 days following pre-prom or until the woman is in established labor, whichever is sooner. It reduces chorioamnitis, prolonged latency, and improved neonatal outcomes. The ideal agent is penicillin if the patient is allergic to erythromycin. Now, when do we plan delivery? Women in whom the pregnancy is complicated by pre-prom and who have no contraindications to continuing the pregnancy should be offered expectant management care as this is associated with better outcomes compared with early birth. Early delivery may be preferable when pre-prom occurs beyond 34 weeks of gestation in women who have colonized with group B streptococcus infection. Now, indications for termination, features of chorioamnitis, POG more than 34 weeks, advanced lung maturity if measured by LS ratio, non-reactive CTG, and obviously on ultrasound findings of severe IUGR or oligohydramnios or severe placental insufficiency. Now, preferred route, talking about the preferred route of delivery, we can discuss the general benefits and risk of cesarean section and vaginal birth with women in suspected, diagnosed or established preterm labor and women with pre-prom and their family members and then decide. The cesarean section should be considered for women presenting in suspected, diagnosed or established PTL between 26 and 36 plus 6 weeks of pregnancy with breech presentation. Now, talking about the management of preterm labor at 34 to 37 weeks, we can refer to this chart. If a patient comes with threatened preterm labor, that is uterine contraction without dilatation, we can screen the patient, signs and symptoms. If they're positive, we can put her on surveillance and manage her. The immediate measures to be taken within 24 to 48 hours are tocolysis, which can be given parenteral. Atosiban is the nifedipine is the drug of choice. Atosiban is the drug of choice. Corticosteroids for antenatals. Corticosteroids cover for fetal lung maturity, and magnesium sulfate for neuroprotection. The maintenance dose, it is not recommended nowadays. Diagnose preterm, the screening, signs and symptoms, if they are positive, we can put her on surveillance. The management is done by tocolysis, corticosteroids, and magnesium sulfate. Established preterm, uterine contraction progressively, cervical dilatation of more than 4 centimeters. We have to plan for delivery. We have to ensure the neonatal intensive care unit, and obviously we have to give magnesium sulfate and corticosteroids. In cases of preterm prom, the diagnosis and when the diagnosis is made, the management has to be done without infection, not in labor. We can give her expected immediate measure 24 to 48 hours is again tocolysis, corticosteroids, and magnesium sulfate. And with infection, then we have to plan the mode of delivery after covering the patient with corticosteroids. Now, according to these guidelines, I have made this table. The ACOG guidelines, the FOXY guidelines, and NICE guidelines recent. The gestational age, which defines the preterm labor, is 20 to 36 plus 6 weeks of gestation in ACOG and FOXY. And NICE guidelines recommend 22 to 36 plus 6 weeks. The first line tocolysis is nifedipine, according to ACOG. FOXY, it also recommends nifedipine and atosiban. NICE guidelines, it recommends nifedipine and atosiban. Maintenance tocolysis is not recommended by ACOG and NICE guidelines, and it is recommended by choice by FOX. Antenatal corticosteroids recommended by all the guidelines between 24 to 33 plus 6 weeks of gestation. Magnesium sulfate for neuroprotection is offered up to 31 plus 6 weeks of birth if the birth is imminent by all the guidelines. Then the vaginal progesterone. Talking about vaginal progesterone, it is recommended for singleton pregnancies with short cervix, that is less than 25 before 24 weeks of gestation. And the FOXY guidelines recommend vaginal progesterone and cervical circulage based on the risk profiling and cervical length. And so does the NICE guidelines. It recommends vaginal progesterone plus cervical circulage with history of, according to the history of preterm labor and cervical length of less than 25 Coming on to the take-home message, in cases of preterm labor, we have to do a risk assessment, then can plan vaginal progesterone according to the profile of the patient and cervical circulage. Main thing, then coming on to tocolysis, antenatal corticosteroids, neuroprotection, antibiotics, and then discuss the mode of delivery. Thank you so much.